Ladies and gentlemen, please welcome Maria Elena Pierobon to the stage.
Okay, so in the next 15 minutes or so, I'd like to talk to you a little bit about our experience with breast cancer and developing novel platform for identifying predictive biomarker, and then bringing those biomarkers into clinical trials so that we can use them to stratify patient to treatment. And in particular, I will focus the talk on breast cancer, and the second part will really focus on bringing those technology together and trying to improve treatment. So when we talk about precision medicine in oncology, the field is heavily driven definitely by genomic profiling. So the vast majority of the clinical trial we hear about rely on genomic information to stratify patients to different types of treatments. However, when we look at actionable oncogenic drivers in cancer patients, there is a relatively low frequency of those alterations. And so precision medicine is really available for a subgroup of cancer patient, leaving out a big portion of the population. However, when we think about tumorigenesis, every alteration at the DNA level then manifests as a functional alteration in the gene product, which are proteins, and not just in individual proteins, but in the molecular networks in which those proteins are contextualized. So when I think about cancer, I really like to think about it as a disease of aberrant signaling network that is driven by post-translational modification and protein subcellular localization, all elements that are extremely hard to predict by genomic information alone. And so we need to do something different in order to really understand how those networks work in different cancer patients. And the other important aspect is that the vast majority of the FDA-approved compounds that we use to treat those cancer patients actually directly target nodes of those different signaling networks. And so we see more and more platforms coming in our laboratory, able not only just to capture protein expression, but really trying to understand functional alteration at the proteomics level. And those platforms usually are able to be high-throughput technologies and multiplex so that multiple biomarker samples can be analyzed at the same time. And they generate semi-quantitative data on broad-scale profiling, starting usually from very small amount of biological material, which is what we need to have in order to bring those platforms forward into clinical practice. And most of those laboratories are also now, those technologies, are also run in CAP-clear accredited laboratories, so they are highly regulated, and they can really become companion diagnostic. And I would like to talk to you a little bit about the reverse phase protein microarray, which was a technology that was invented by the co-director of the center where I work at George Mason University. And you might be familiar, I just give you a brief overview. So the reverse phase protein microarray is pretty much a miniaturized immunoassay, where hundreds of samples can be immobilized concomitantly onto a solid substrate. So the way that it works in our laboratory, we use the 24/7 arrays that is part of the Quanterix panel of instrumentation. We have the ability to immobilize up to 900 samples in technical replicates on each assay. And from a small amount of material, something like 10,000 cells, we have the ability to measure 150 to 200 protein, both at the expression level, but more importantly at the post-translational modification level, so that we can really capture the dynamic within the signaling network. We have a library of over 400 antibodies that have been validated so far, both in terms of specificity against the target that they are supposed to recognize, but also linearity once you use them on the assay. And this platform pretty much allows us to really capture activation level of low abundance protein and even measure some of the transcription factors. So over the year, the RPPA has been compared to different diagnostic platforms. Here, I'm just showing you some examples that concern expression level of HER2 and comparison with FDA-approved testing like immunohistochemistry or FISH. As you can see, we have very high level of concordance between the RPPA and both FDA-approved platforms, with a concordance level between 93% and 95%. And when we look at overall expression of HER2, you can see we have a very nice positive population by both FISH and RPPA, and then we have a very nice negative population that is clearly separated from the positive patients. One aspect I would like you to focus on is the dynamic range that we are able to capture in terms of HER2 expression that is a little bit lost with the other FDA-approved platforms that are used routinely in clinical practice. But then we also started looking at phosphorylation level of the receptor, and as we expected, patients with amplified HER2 have very high activation level of the receptor itself. But when we look at the FISH negative population, we started identifying subgroup of patients with very high activation level of the receptors. So this is a group of patients that right now is not eligible for treatment with an anti-HER2 agent because by all conventional diagnostic testing, it's considered as negative. So Dr. Petricoin and Dr. Wolfkohl had the opportunity to explore the role of those high phosphorylation level in phospho-HER2 in breast cancer in response to therapy using some of the sample collected through the I-SPY2 trial. As Justin mentioned before, this is a very large nationwide trial that utilizes neoadjuvant chemotherapy before the patient undergoes surgery. And the trial is designed so that all the patients receive standard of care plus or minus an investigational agent. So the data that I'm showing now are collected through the neuratinib arm. So patients were treated either with standard chemotherapy or standard chemotherapy plus the pan-HER inhibitor neuratinib. Along the clinical outcome of the trial, the I-SPY consortium has also a very strong biomarker analysis component, trying to identify predictive marker of response to different treatment, so that when those drugs move to a phase 3 type of trial, potentially they can come in with a companion biomarker that will help the stratification of patients so that we can test the biomarker and the drug at the same time. And so of all the different biomarkers that were analyzed during the I-SPY2 trial of patients treated with neuratinib, none of the biomarker but two emerged as potential predictor, and both those biomarkers were the one measured by RPPA. And in particular, the two biomarkers were the activation level of HER2 and activation level of EGFR, two of the direct drug targets that the drug interacts with. And here, I just want you to just look for a minute at the data that were collected for the triple-negative breast cancer patients. So those are patients that usually don't receive an anti-HER2 agent, because by standard testing, they usually are considered not overexpressing the target protein. Here, we can see that in the treatment arm, where triple-negative breast cancer patient received neuratinib in combination with chemotherapy, patient that had very high expression level and activation of HER2 and EGFR reached a pathological complete response, while patient that had very low or lower activation level of the two biomarker did not reach a pathological complete response. Through different Bayesian analysis, it was estimated that approximately 43% of the patients in this cohort presented with this specific signature. So even in a cohort of triple-negative breast cancer, a quite significant proportion of patients presented with high activation of EGFR and HER2. And the probability of reaching pathological complete response in this population of patients with this specific signature was approximately 75%. So indicating that even in this population of patients where we usually don't use this type of compounds, there could be potential clinical benefit if we can identify them from the general population. So now we have further developed the RPPA assay so that it can become, in the future, a companion diagnostic. What we have done is we have built in reference standard curve on each of our assay and positive and negative control that allow us to track the performance of the platform over time and adjust if needed with some of the variables like we was mentioning this morning, changes between reagent lot, etc. And this also allows us to directly compare across different experiments, compare an individual patient to a reference population, or compare different patients that are captured and collected at different time points. So this is just a little roadmap that we have created. So we receive a tumor biopsy. We usually go through cellular enrichment so that we can isolate the tumor cells from the surrounding microenvironment. And then with the reverse phase protein microarray, we can really capture the activation level of a lot of different signaling pathways, including some of the molecules involved in immune signaling. And pretty much through this approach, we now can measure the direct target of almost all FDA-approved cancer compounds. So after all of this, we were also able to test the powerful of the platform in the context of a prospective clinical trial. So these are data that were collected through a phase 1/2 clinical trial sponsored by a private foundation that's known as the SideOut Foundation. And in this clinical trial, we worked with metastatic breast cancer patients that had already failed at least 2 lines of chemotherapy. And the idea of the trial was to use multi-omic technologies to identify actionable alteration in individual tumors to see if we could broaden the number of patients for which precision medicine becomes a real option. So this was also a nationwide trial. We had 4 different enrolling institutions. Patient entered the trial and received a biopsy of the metastatic lesion at the trial enrollment. So we were really working with the lesion that was growing at the moment of trial enrollment. And then this biopsy was sent to 4 different laboratories. We had target exome sequencing and RNA-seq performed on the samples. We had a multiplex IHC. And then in our laboratory, we covered the RPPA with a concentration on a panel of receptor tyrosine kinases, their activation, and the activation of downstream signaling substrates. All the molecular profiling were collected in approximately 14 days, and then it was given to a tumor board. And then the tumor board would select an FDA-approved treatment or combination treatment for each patient. So we were not testing any experimental agent in this trial. We were just testing the idea of matching the right patient to the right drug and see if that could somehow improve clinical benefit. So the primary objective of the trial was to see if this multi-omic approach was really able to somehow benefit metastatic breast cancer patients that had already developed resistance to previous treatment. Outcome measurement was achieved using the growth modulation index, which is pretty much a ratio between progression-free survival the patient achieves when on trial, divided by the progression-free survival the patient had in previous treatment. In order to be beneficial for a patient, it was established that the GMI needed to be at least 30%. The progression-free survival needed to be at least 30% longer than on previous treatment, and that this type of data should be collected in at least 35% of all patients. So the first thing that I want to point out is that all the molecular information were collected on an average of 14 days, so something that's highly compatible with clinical management of those patients. So the treatment was given immediately to the patient. The patient didn't go through a first round of treatment and then the information were used in a second moment. So it really happened in real life. Here is just an example of all the different data that were collected. And again, the RPPA and the immunohistochemistry were the only 2 platforms that were able to generate data for all 25 patients, indicating again that they are highly effective in analyzing and in providing data on even using small biopsies. The most important data that came out of the trial was that this type of approach allowed us to identify targetable alteration in each single patient, so really trying to broaden again the number of patients that become eligible for this type of approach. For almost all the patients, the treatment that was selected based on the molecular information was different than the one that the physician would have empirically selected, again indicating that there is a clinical utility in providing this type of profiles to the physician. And I think the most important data that we collected through this trial was that 56% of patients actually reached the primary objective of a GMI greater than 1.3. Again, indicating that in a population of patients with refractory disease that had already received a different line of chemotherapy, we were able to improve the progression-free survival interval in more than half of the patients. And so going back to the HER2 story that I was telling you before, I just want to show you one example of one of the patients that was enrolled in this trial. This is a 48-year-old woman that had liver metastasis when entering the trial. Data from the multiplex IHC and the RPPA were used to select treatment. In particular, the thymidine synthetase was low, and so the patient was recommended for capecitabine. This was a HER2 negative patient that had very high activation level of all the receptor of her family, and also high activation level of the downstream substrate ERK. So lapatinib was added to the treatment. So the patient was treated with capecitabine plus lapatinib and obtained a GMI of 2.8, increasing significantly the progression-free survival interval for this patient. So in summary, I just would like you to take a few points home as a take-home message. Definitely the RPPA represents quite a unique technology for measuring post-translational modification and for capturing signaling network in patient samples, even in small core needle biopsies. This type of approach that we use, the multi-omic approach, by combining different omic techniques with genomic sequences, has definitely increased the number of patients that become eligible for targeted treatment. The delivery of those complex genomic and proteomic profile can be achieved in a relatively small time frame. And the most important part is that this approach really provided clinical benefit in approximately 50% of patients that were enrolled in the trial. And a big thank you to everybody that worked on this project with us. And of course, a big thank you to the patients that have been enrolled in the trial.